Good evening, everyone. We're going to start. I'm going to introduce Dr. Kayci Huff from Mercy Hospital. She is going to talk to you about staying on your medications. I also want to thank some of our sponsors. Takeda Pharmaceuticals, Johnson & Johnson, Gilead, and Pfizer. I also want to thank all of our wonderful volunteers that help make these events happen. Dr. Huff, you have the virtual stage.
All right, good evening, everybody, and thank you for joining us on a chilly Tuesday evening. Tonight, I'm Dr. Huff. I'm one of the GI physicians at Mercy Hospital in St. Louis, and tonight I'm going to talk about inflammatory bowel disease and why it's important to be on medications once that decision is reached with your physician. So I like to start all of my talks with just a little bit of an overview. I don't know if you were at my talk last year, but I called my talk, I have IBD. So what does that mean? I think it's important for those who have the disease, as well as those who support people or are close family members of people with inflammatory bowel disease, to understand that this is a chronic disease. That means it's lifelong. It's not something that happens and then it goes away like a cold or a flu. And it's caused by inappropriate inflammation in the GI tract. There's not a cure for it. It's not something that you take an antibiotic for and you get better and it's gone. Now we have lots of good options to manage the disease, and we can actually get you into remission. And our goal is for you to have a normal lifestyle. You, the patient and family members, as well as your gastroenterologist and our staff, form a team together with, and we all have the same goal in mind. Our goal is for you to feel well, do well, and live a completely normal life. And then within the umbrella of inflammatory bowel disease, there's two types. There's ulcerative colitis and there's Crohn's disease. So I don't know if this depicts your life, but this is a guy, he's been running a marathon and he's running and trying to find a bathroom. And this is not what we want for your life to look like every day. So I wanted to start with ulcerative colitis. Ulcerative colitis, as you can see in the name, is characterized by ulcers in the colon. It can occur anywhere along the GI tract. It always starts in the rectum and it can extend upwards and involve the entire colon. It's limited to just the shallow layers of the colonic wall. This is what a normal colon looks like. So if you're eating dinner, I'm sorry, but this doesn't disturb me. I look at this every day. This is a beautiful, normal, healthy looking colon. You can see there's some nice blood vessels. You can see it's shiny, the light's reflecting off of it. But when you have ulcerative colitis, it has a look like this. It looks almost like sandpaper's been rubbed against it. And you can see that there's a lot of irritation. There's some shallow ulcers and some mucus. Crohn's disease, in contrast, can affect anywhere along the GI tract, involving the colon, small intestine, as well as the upper small intestine and the stomach. Most of the disease involves the last part of the small intestine as well as the colon. It can actually involve the deeper layers of the colon or small intestine wall, and there's basically three types of Crohn's disease. There's one that just has inflammation. There's a type where scar tissue forms and causes narrowings. And then there's one called fistulizing or penetrating disease, where tunnels can actually form between two hollow organs. So from small intestine to small intestine to colon, or other organs, including skin, bladder, things like that. The inflammatory type is normally characterized by abdominal pain, diarrhea, weight loss, obstruction. You can get cramping, abdominal distension, like your stomach gets really big, as well as nausea and vomiting. Fistulizing disease, you can get diarrhea, pain. You can get air and feces or urine if it involves certain organs. And as we talked about, there's multiple different types. So when we watch TV, we see commercials for all sorts of medications and they talk about the side effects. The things that they don't talk about are what are the long-term complications of not treating the disease. And I think that it's important to understand these as we talk about why it's important to take medications and be on therapy. So long-term complications include infections. If your disease is poorly controlled, you're at risk for infections, including C. difficile colitis, as well as CMV, which can not only affect your GI tract, but can also affect your bone marrow, your eyes, and your central nervous system. Also, your immune system is inherently weaker than that of a normal person's because it's distracted as it's too busy attacking its own GI tract. Colon cancer is another long-term risk of having uncontrolled inflammation. If you have long-term inflammation that's not treated in the colon, your risk of colon cancer is much higher. Also, if you are someone who's affected by Crohn's or ulcerative colitis, you know that you don't feel good when your disease is active. It can also lead to anemia or low blood counts, vitamin deficiencies, and fatigue. It feels like you have had the flu or are sick with the flu. Structural damage is what I call this. Longstanding inflammation can lead to the walls of the GI tract being stiff. You could also get perforation, which is a hole that forms and that can cause an infection. Stricturing or narrowings in the GI tract, like we talked about in Crohn's disease, those fistulas are tunnels. And once we get to a point of having structural damage, this damage can't be reversed with medications and oftentimes needs surgery, or we have to treat around these structural issues to control your symptoms. There can also be fertility issues associated with longstanding inflammation or surgeries. So we want to prevent these structural issues. And in the inflammatory bowel disease literature, they talk about a window of opportunity. And so what this talks about is treating you early before we actually have structural issues and we're beyond the point of no return. We used to think that Crohn's disease and ulcerative colitis were just these what's called relapsing and remitting disease. And what that means is that you have a flare, you treat the flare, and you go back to your starting point, and then you may have a flare again, and so on and so forth. And that's illustrated here in this line. This is a little bit strange to do without a pointer, but this line here shows these little peaks and valleys always coming back down to a baseline. But what we know, since we've been treating this for a longer period of time, is that actually it doesn't always go back down to baseline, and the inflammation just smolders and causes long-term complications, including narrowings, fistulas, and eventually may lead to surgery. So the goal is to treat you in this early phase and treat you well to prevent these outcomes down the road. So how do we treat it? We have many different options actually that are medications aimed at controlling the immune system. We have topical medications, and so when I say topical, oftentimes we think of a cream or an ointment that we put on our skin, but basically these are topical therapies for the colon or other parts of the GI tract, and are typically mesalamines, and they can come in pills which open up in the colon and treat you there. They also come in suppositories or enemas depending on where and how extensive your disease is. Steroids, this is prednisone as well as budesonide, Entecort, or Uceris. These medications are not meant for long-term use. These are sort of like a fire extinguisher. So when your disease is very, very active, we give you steroids just to cool down or quiet down the entire immune system. Then there's medications called immune modulators that sort of alter the immune system. This is mercaptopurine, Imuran, or methotrexate. In 1999, our first biologic medication came along, and it was Remicade. Biologic basically means that this is a protein-based therapy, and it's an antibody directed against a certain type of cytokine or immune driver in the immune system. So there's the first ones we had were the anti-TNF therapies, and this is Remicade, Humira, Cimzia, and Simponi. These medications I call our hand grenades. So they're very, very good, potent medications, but they suppress the whole body's immune system. Our next type of therapy is our anti-integrin or Entyvio. This was released in 2014 and is really our first and only medication directed at Crohn's and ulcerative colitis specifically. I say it works as a smoke screen, so it's basically blocking new inflammation from coming into the GI tract. And then we have another therapy called Stelara. This is, it's called an anti-P40. It's an anti-cytokine. So it's a more narrow type of therapy than the anti-TNF, but it still does suppress the whole immune system. So we have three major classes of biologics. And then we have one new drug that's approved for ulcerative colitis, but not Crohn's disease, called Xeljanz. That's a pill, and it works by suppressing the whole immune system as well, but seems to be a little bit different and maybe more targeted than the 6-MP and methotrexate. So whenever I start a medication, the first question I get is, how long do I have to be on medication? And here I have a picture of a fireman putting out a fire, because that's what we want to do. So first, before we even have this discussion, we need to make sure that the medication works. So there's no point in having you on a medication if the medicine doesn't work. And the medicine working, we sort of use two things to determine that. One is how you feel. And we used to think that if you felt well, that meant your disease was under control and we were happy. However, in more modern days, and since probably 2015, we've decided or learned that it's important how your GI tract actually looks, because how you feel and what the GI tract look like don't always match. We have learned that if we can treat you to the point where your GI tract looks completely normal, your risk of having adverse outcomes, including colon cancer or structural damage down the line, is much less. You're also more likely to do better in the long term if we can get you in good control or deep remission, meaning your colon or GI tract looks normal within the first year. So we want to treat the inflammation and then keep the disease under control. Again, like I said before, there's no cure. So even once the disease is controlled, the inflammation is still lying under the surface. So typically, once the disease is controlled, we decrease your therapy. So sometimes that means starting you on steroids and taking away the steroids. Other times when we start some of the newer medications, we give you a high dose of the medication up front, and then we give you smaller doses that are spaced out further once the disease is under control. So I decided to actually pull up some data from some trials on stopping medication. So what happens if we stop our medication? So this is a study where patients were on anti-TNF therapy and they were in remission. They were also on a second therapy, either Imuran, 6-MP, or methotrexate. And when they stopped the medication, after about 9 months, about 40% had a relapse in their disease, and after a year, about 50% had a relapse of their disease. There was another trial called the STORY trial that looked at similar things, and they found that within 7 years, 66% or 2/3 of the patients that stopped Remicade needed to restart their treatment, and 20% of these patients actually developed fistulas in their anal region. So this first study I talked about then we always like to figure out if we can predict who is more at risk of having a relapse of disease or needing therapy longer or needing a certain therapy. So they looked at different factors that may be associated with higher risk disease. And here they divided it out by the number of risk factors. And so you can see that the more risk factors that you have, the more likely you are to have a relapse of your disease in a shorter amount of time. This is what's called a survival curve. So if you survived or didn't relapse, you would stay here at 100%. And the faster the decline, that means the faster the patients relapsed, or the more relapsed. So they found that if you use steroids or needed to be on steroids between 6 months to a year before stopping medication, you are at a higher risk. If you hadn't had a previous surgery, probably meaning that you might have some structural damage and need a surgery in the future, they found that men were at higher risk than women. And we sort of know in the IBD community that men seem to have more aggressive disease. If your blood counts were low, if your white blood cell count or your inflammatory marker was higher, if you had clinically active disease, so that's based on what you're telling the doctor, your risk of relapse was higher. If you had a CRP, which is one of our inflammatory markers, if your level was high, then you are at higher risk of having a quicker relapse. A Remicade level showing that the drug was high in your system, or a fecal calprotectin level, which is a marker of inflammation in the stool. If that's elevated, you are at higher risk. So the more of these that you had at the time the drug was stopped, the higher your risk of having a relapse in a shorter amount of time it was. So that being said, I have people ask me all the time, can I stop my medication? And I think this is a very reasonable talk to have. And so I don't think that there's a blanket statement across the board. I think it depends on multiple things. So one, how well have we treated your inflammation? If we treated your inflammation well, you've never had a surgery, you don't have any of these high risk factors, then maybe it's reasonable to give you a trial off of medication, or maybe not off of medication, but decreasing to a less potent medication, or maybe trying to start spacing the interval between therapies. Risk factors like we talked about. So if you have smoldering disease, or I can see inflammation on your endoscopy, I'm probably going to tell you, no, we can't stop your medication because you're at high risk of having a relapse. If you've had multiple surgeries and a relapse of your disease might result in losing more of your bowel, then I would tell you we can't stop your therapy. And again, over 50% of people who come off of therapy have a relapse. So we always want to think about what you have to lose. And the other thing is that if we had you in good control before, the medicine that we use to treat you may not work anymore. And that can be for several reasons. One, your disease can change somewhat. And two, because many of the therapies are protein-based therapies, your body can actually build an immune response to them when the level drops low, like what would happen when we stopped the medication. Just like getting a vaccine for the flu, your body builds up an immune response. You can build up an immune response to these medicines, and that will make them not work anymore. So just to kind of summarize here, inflammatory bowel disease is a really difficult disease to live with. It's a chronic disease. It really affects your life. Our goal is to treat you well and to treat you early to help prevent or minimize longstanding complications from the disease. You should talk to your doctor about concerns when you start any therapy. And then if you stop therapy, there is a risk of relapse. And so again, this should be a decision that you make with your GI doctor. And if we make that decision together, it doesn't mean that we never see each other again. Actually, many of my patients that stop therapy, I actually see them more because we need to do close monitoring to watch for relapse of their disease. And the earlier we can treat a relapse, the more likely we are to get them back under control. And again, if you relapse, the medicine that we used before may not work again. I also have patients that have been on multiple medications, and those are patients that I would be very hesitant or reluctant to stop their therapy and let them have a drug holiday or a trial without medication, because I may not have any other option to treat them if their disease was to relapse. And with that, I will leave you. And this is just a depiction of my life. So this is Piglet shining a flashlight down the toilet. And somebody says, "Why are you shining that flashlight down the loo or toilet?" And he says, "I'm looking for poo." So with that, I will hand it back to Dan.
Thank you so much, Dr. Huff. Next, I would like to introduce Katie Willard-Virant. She's going to talk to you all about IBD and trauma. Katie?
Thanks, Dan. Hi, everybody. It's really nice to be here. I wish we could all be in the same room together. I'm sure we all do. It's been quite a year. I am going to speak about trauma. Well, let me back up and introduce myself. As Dan said, my name's Katie. I'm Katie Willard-Virant. I'm a psychotherapist practicing in St. Louis. I live with Crohn's disease. I've had Crohn's since I was 18. In my practice, I treat many people with IBD and other chronic illnesses. I feel that the emotional toll that IBD takes on people has been understudied and under-recognized. So I'm really passionate about educating people, talking to people, kind of validating people about this. And I chose the topic trauma. I write a monthly column for Psychology Today about different emotional aspects of living with chronic illness. And I did write a column about trauma, and it got a ton of hits. It really resonated with people. I think that most of us who live with chronic illness do experience trauma. Whether that turns into a post-traumatic stress disorder is something else, and we'll get into that. But in terms of experiencing trauma as a result of living with IBD, I think it's something that when people understand what trauma is, there's an aha moment of, yes, this has happened to me as well, living with this illness. So let's talk about what trauma is. Trauma is the intense fear or perceived threat to your life or someone else's life. I'll repeat that. Trauma is the intense fear or perceived threat to your life or someone else's life. It's a situation in which the self is overwhelmed by the experience. Our nervous system, particularly our fight or flight system, is on high alert. That's our fire alarm, right? Our nervous system tells us when we're in danger. And it's like a fire alarm system responding to a fire, saying there's danger here, doing exactly what it's meant to do. There have been many times, I'm sure people listening to this talk have had that experience. Your gut hurts, you're in pain, you're experiencing symptoms. There's going to be some heightened anxiety. Your nervous system is going to let you know things are not right here. Get help, right? So, most of us have had pain with IBD. Some of us may have been in situations where we would have died without immediate medical attention. Sometimes medication and surgeries and hospitalizations cause their own traumas. So I want to say that not everyone who has trauma goes on to develop a post-traumatic stress disorder. Statistics vary, but about 1/3 of people who experience trauma will go on to develop that. So trauma is upsetting. Our system is saying, I'm not able to cope with this. And that's a good thing, right? Just like a fire alarm in our house tells us there's a fire here, there's a problem. That's a good thing. Our nervous system is working well. What we want, though, is when the fire is put out, for the fire alarm to stop, right? So what happens with a post-traumatic stress disorder, the trauma sticks with us. We haven't integrated it into our sense of self. The fire alarm is saying there's still a fire going on, but it's not going on anymore. We're not in real danger. So what we've found is when that happens, when people haven't been able to integrate a trauma, they haven't been able to store the memory properly. They haven't been able to store the experience properly. If you'll notice, when we are in extreme distress, sometimes that experience can feel very fragmented. It can come at us in bits and pieces. It can come at us in terms of senses, a smell, or quick flashes of sight or hearing. So there are ways that what we found protective when we experience something is to be able to put a narrative to it, to say this happened, then this happened. When we're in the middle of something traumatic, we can't do that, of course. But after the trauma, it's protective to be able to do that, to tell the story of what happened to us. What happens with traumatic memory is that there's a feeling of confusion, maybe a swirly feeling, kind of a feeling that time is disjointed, that things don't follow logically. Lots of times what we'll see is people not able to put it into words, or a feeling that it's too painful to put into words, a wish to push it away. So it can be really difficult to do that, to give voice to traumatic experience. And I'll talk a little bit later about how therapy can help with this. So one pattern of symptoms that we see a lot when we have difficulty processing trauma is alternating between hyperarousal and numbness. So Dr. Huff just told you about the window of opportunity for treatment, and I want to talk a little bit about what we call the window of tolerance. So the window of tolerance for our emotions is, if you picture a window, just picture your kitchen window maybe, that's where things are going okay, right? Things are in control. It's not that everything's rosy necessarily, but we can manage what comes our way. Above the window of tolerance is what we call hyperarousal. That's where we feel anxious, jittery, our heart might be pounding, our thoughts are moving really quickly. And that doesn't feel so great, right? That high anxiety. Under the window of tolerance is what we call hypoarousal. And that's where there's a numbness, a dissociation, a disengagement from connection, from other people, from experience, sometimes a spacing out, a sense of not being present. That can also show up in the illness context with avoidance, avoiding medical care, feeling, maybe I'll deal with it tomorrow, not going for your scopes, not taking your medication. These are trauma responses. So we know, let me back up though. These are things we all feel, right? You kind of know what I'm talking about at each end, but if we're in a healthy spot, we can get ourselves back to the window pretty quickly. We have tools and the ability to say, wow, I'm really anxious, or I'm really spacing out and numb. I got to get back where I'm feeling things and able to manage. It's when we stay in hyperarousal or hypoarousal, or with a lot of trauma, we see both, people alternating between hyper and hypoarousal. When you're stuck in that and you can't get back to your window of tolerance, that's when you've got a problem and you need to seek treatment. Some of the other symptoms we might see, again, part of this hyperarousal, hypoarousal, flashbacks, nightmares, difficulty sleeping, intrusive thoughts, nightmares. So if these are things that you're experiencing, your nervous system needs treatment. It's out of whack. There's an identity piece of this too. Trauma affects not only our nervous system, but also our self-concept, our identity. So I like to think of identity as kind of a rope. It goes along, it's continuous, right? Developmentally, we're infants, we're children, we're teenagers, we're adults. We have a sense of what our values are, what things we like to do. And sure, things shift and change, but that basic sense of self is there. And trauma cuts the rope. Trauma cuts that rope of identity. For many people, diagnosis and then living with illness, that rope is cut. Things change dramatically. We know that formation of identity, even under the best of circumstances, is challenging. Navigating life as a child, as a teenager, as a young adult, as an older adult, it's challenging. But you're going to have additional challenges living with illness. And the weight of that burden, the weight of navigating different developmental stages, living with chronic illness can itself be a trauma. So I want to talk about how to treat trauma because it's really, really treatable. And this is why I think it's important that people living with illness understand what to look for, that it's not unexpected living with chronic illness. And if you're feeling yourself stuck in trauma, to get treatment, because therapy can really help. So trauma lives in our bodies. It's interesting. I was treating somebody recently, and I made the statement, we don't just live in our body, we are our body. And as someone living with chronic illness, it really was eye-opening to her. She'd spent so much time, and certainly as someone who's lived with Crohn's for so long, I can relate to this. Maybe you can too. We have very uneasy truces with our bodies at times. Our body's been the locus of a lot of pain, a lot of discomfort, a lot of anxiety. So trauma lives there with our illness. Trauma lives in our body. So when I'm seeing somebody who has illness trauma, I'm seeing someone whose body believes they're facing danger at that moment. Again, you might not be in the hospital, you might be doing okay, but your body is your nervous system is reacting as if you're still in that trauma. And that takes a toll. It's not good for your illness. It's not good for your mental health because your body's constantly saying you're under attack, do something, you're not safe. It might not be saying it thought-wise, but it's saying it in the stress hormones that are cascading all over your body, and maybe your racing thoughts, in maybe the numbness or dissociation. Those symptoms are your body's way of saying, hey, we are not safe. So when you're feeling this way, what I like to do with my patients is to really think about, to use this is kind of our amygdala, right? Our limbic brain is saying, danger, danger. And we wanna use our frontal cortex. We wanna use all that gray matter to calm the amygdala down. So I want, when that feeling happens to you, if you're feeling hyper aroused or hypo aroused, to say, am I in danger right now? Not maybe tomorrow, not maybe next year, but at this moment, am I in danger? If you are in danger, if you're having a flare and you need to be seen, go get seen. But if you're not in danger at that moment, we need to work at regulating and calming that down. So kind of using evidence, using data and I think what Dr. Huff was saying, I love how the data's become so sophisticated that our physicians use, that we're getting scanned, we're getting blood tests. There's a way that we have data that tell us what our disease is doing, and our doctors have sophisticated tools to treat us. That can be very comforting and very calming to our nervous system that doesn't quite know that yet. So we got to use our brains to kind of calm down that nervous system. So a couple of things. Treating trauma involves three parts. The first part is emotional regulation. Again, the nervous system is so stressed, so out of kilter. We got to get that back so it's operating at a good level. We got to get that back so that when we do the next part of trauma work, which is making a narrative, that the body is able to sustain that work, that there are ways that when feelings do come alive, do feel painful, that there are tools in place such that we know we can get you back into that window of tolerance. So for emotional regulation, that's the first part of trauma treatment. I recommend that the people I see with chronic illness be practicing both mindfulness and body work. Mindfulness is a practice that orients us to the present moment through attention to our breath and our senses. Meditation's really useful, especially breathing meditation. Sometimes I bring this up to people and they say, oh my God, there's nothing I can imagine that's worse than meditation. It sounds awful. The great thing about meditation is it's not sort of sitting on a mountaintop and, for 20 minutes silently. There are walking meditations. There are guided meditations where there's a voice guiding you through it. There are eating meditations. There are lots of roads to Rome here. So what I do with my patients is explore what works for them. Mindfulness these days, it's flexible. You can find a way for mindfulness to work for you. Tons of apps out there, lots of information on the web, and a good therapist can guide you through this too. A meditation that I really like, if anybody's interested, this is one of my personal favorites, Kristin Neff, N-E-F-F. Her work is about self-compassion. She has a really nice breathing exercise on YouTube. So if you're interested, just as a way to kind of try this out, look up Kristin Neff Yin Yang breathing exercise. It's a great, short, guided meditation. And again, if that doesn't work for you, maybe it'll give you some curiosity to try out some other apps and websites. Let's see, grounding exercises are also really important, both in terms of anxiety and numbing, that hyperarousal and hypoarousal that I was speaking of. Those are ways of taking us out of the present. And we want to be present. We can't really live our lives if we're not in the present. So good grounding exercises kind of help bring us back. Again, really, really personal, really varied. One exercise that works that I like in the interim, especially if someone in session is having a hard time either calming down or waking up to feel their feelings, is to invite them to put their feet flat on the ground to really feel the contact with the floor, feel their butt in the chair, take a couple of deep breaths, and then use their senses. Tell me 5 things that they see, 4 things that they hear, 3 things that they smell. Finding a way to come back to the present. For a lot of my clients, being outdoors is helpful. Walking outdoors, and if that feels too taxing, even just sitting outdoors, again, using our senses, noticing the leaves, hearing the birds. If you're feeling like you're having a hard time orienting to the present, wake up those senses. If you're at home and you can't get outside, I like to tell people or advise people to make a nice cocoon. Sometimes we're stuck on the couch, right? Find a spot near a window, light a candle, play some music that you like, anything to wake up those senses to keep you in the present moment. Body work is also really important. Again, I think that those of us that live with illness have complicated relationships with our bodies. And there's a lot of times that illness has created a distance or a mistrust in the body. I recommend gentle stretching or yoga or walking, swimming, whatever feels restorative. It shouldn't be another to do. It should be something that helps you feel in touch with your body. Again, waking things up, feeling alive, feeling connected. I wrote a column about exercise and chronic illness. I think it's a complicated issue. Again, that relationship with our body is not the easiest, and exercise is going to wake up feelings we have about our body. Again, working with a therapist can help you work through that, to find a program that works for you and helps you feel in your body, like you're not working against your body. So once I feel that we have the tools of emotional regulation in place, that clients have gotten better at bringing themselves back into the window of tolerance, they're having more stability in their nervous system, we can begin the cognitive processing. And I work with clients to create a narrative of the trauma. I think it's really important in long-term illness. We're lifers. This is what we live with. And we've had to cope with so much for so long, lots of twists and turns. It can feel sometimes impossible to put into words the whole story of what has happened to us. But in doing this, we can begin to store the memory as something that did happen to us, not something that keeps happening now. And you might say, well, the thing with chronic illness is it could and likely will happen again. That's true. That's a hard thing. Especially IBD, it's a disease with a lot of what ifs, kind of what we've been through, that we could go through it again, and there are bumps in the road. What I think is important in looking at the what ifs is self-efficacy. So a belief that the locus of control is within us, to the extent that it is, of course. We have to strengthen the belief that we'll get through this, that we'll find a way. Some of the what ifs: what if my illness worsens? What if my meds stop working? What if I get an infection? What if I flare? I help my clients to lean into those what ifs, not in a sense of sticking with them and ruminating on them, but in a sense of making a plan, so that we have action plans, so that when your brain goes to, well, what if, you have a plan. You say, well, if my illness worsens, I will call my doctor right away. I think too, we're lucky here in St. Louis to have really good IBD doctors. I mean, these are people really dedicated to working with us long term. So use those resources, use your doctors to help you make a plan. That those what ifs shouldn't be ruminated about, but they can give you the impetus to ask the questions that you need to ask. And I think having those action plans that you can refer to, so when your brain goes to what if, and you remind yourself, I have this action plan. So that's all. I don't need to think about it now because it's not happening. But if it does happen, I do have a sense of control and a sense of what I will do if this thing happens. And of course, there will be times when we don't have control. I think so much of living with IBD is sort of taking control of the things that we can take control of, like keeping our emotions nicely tuned, doing that body work, doing that meditation, making a good action plan with our physicians, keeping ourselves in as good health as we can be, but also acknowledging, as with all people, not just people that live with IBD, there are things that we can't control and things that we don't control. And I think that there are feelings that come up about that. We're not good as a culture at leaning into what we don't control. And that's another space that therapy does a really good job at addressing, of helping hold those feelings, figuring out what we can control and looking at what we can't control and honoring the feelings that come up with that in such a way that it can be worked through. And again, doesn't have to live in your nervous system as a constant fire alarm. So that is the end of what I've got in my notes. I gave this talk actually to a group last year, and I'm just looking at their questions, seeing if I want to go over anything. Somebody asked, sometimes I relive a past trauma, an intrusive thought or flashback, and it triggers depression. Is this normal? Yeah, absolutely. It's really, flashbacks are really unpleasant. Ruminating is really unpleasant. Again, I think trauma, it's a time traveler. It steals us, it yanks us out of the present. We become obsessed with something in the past or obsessed with worrying about what's going to happen in the future. And yeah, of course it triggers depression because we're not living our lives. We're not in the present living our lives. We've been hijacked to, again, the past or the future. Another question that group asked is, I feel like PTSD related to chronic illness is not addressed at all. There's only talk of anxiety and depression. Is there a reason for this? I think that's changing. I do think trauma, anxiety and depression can be and often are symptoms of trauma. And given that we live with IBD, we are living with something really stressful, we've experienced trauma, right? So whether that trauma turns into something that we get stuck in, or whether it's something that can be worked through, if you get stuck, nothing wrong with you. It gets stuck sometimes. This is what we treat in therapy to get you unstuck. So keep it in your mind. If someone is saying, oh, I think you're depressed or you're anxious, Could be, but could also be a symptom of trauma. And especially living with Crohn's or colitis, you are at higher risk for that. Someone else asked about coping skills for someone that experiences anxiety about declining health. That, I think that's that what if that I was talking about, sort of sorting through the things you control, the things you can't control. There's a lot of grief work with the things we can't control, right? We are all vulnerable, not just those of us that live with IBD. We are vulnerable people. And there are a lot of feelings that come up around that vulnerability that they can be talked about and addressed and worked through. Any questions? I know Dan is handling that, but I'm happy to hear any questions or comments. And thanks for your attention.
Folks, if people want to type their questions into the Q&A box, we can both answer questions in private through the Q&A box, or we love to be able to verbally answer questions. So if there are things that you don't mind us answering out loud, we would like to do that too. I want to say, Katie, thank you for that talk. You know, I am a convert. I was skeptical about meditation, and I think it's the greatest thing now. I feel better and more calm after I do it. Like it gives me kind of a mental boost in the middle of the day. So thank you for bringing that up. I will go ahead and read the first question, and we will direct this one to Dr. Huff. Why would someone want to stop their meds since there's a chance that the meds may not work again and there's a limited number of meds available?
Right. Well, that's a great question. And sometimes I feel like I ask myself that question when patients ask me that question. So I think everybody has their own feeling on medicines. I obviously am a traditional medicine doctor, and I use medicines that I believe and have been shown to have efficacy and work through rigorous studies, and I understand their safety and their use. But again, we watch television, we read fine print, we talk to the pharmacist, and you see that nothing comes for free, whether that be untreated disease or medicines that we take, or even any decision we make in life. But these medicines may have risks, including some cancers, increased risk of infections, as well as Xeljanz has an increased risk of blood clots in some populations as well. And so oftentimes people are very concerned about the side effects and what will this do if I take it long term, and why would I want to take something if I'm feeling fine? And so I almost never initiate a talk about stopping medication unless somebody's on a subtherapeutic dose and I don't think the medicine is doing anything. In that case, I would be the one to initiate that conversation. But if a patient comes to me and they're very concerned about the medication that they're on and they want to stop it, then these are the things that we talk about before we de-escalate. But those are all very important and valid points, and points that I think are important too. You know, one, if we flare again, remember how bad it was and how you felt, and we may not get back to this point. I understand your concern about the medication, and so we have to make sort of an informed decision moving forward together, and monitor closely.
Thank you. The next question we'll direct to Katie. Katie, is stress harmful for IBD patients?
Sure, stress is harmful for all of us, but yeah, it definitely, we know this, it affects the course of our disease, it affects the quality of our life. And we have stress, right? I mean, it is stressful living with IBD, but there are so many creative ways to manage stress, ways that really work. So sometimes people say, well, I'm just a stressed person, or this is just the way it is. That's not true. There are ways to mitigate, manage, deal with, reduce stress. If there's one thing you take away from my talk, it's please let it be that stress can be reduced, and it's good for our physical health and our mental health for that to be the case.
Thank you. Next question I will direct to Dr. Huff. Would you recommend an MRE or CTE to follow up for stricture inflammation after an upper small bowel resection and being on Remicade?
Sure. I read that question too, and that's a great question and a great point for clarification. So calprotectin is a surrogate marker for inflammation in the colon and can also be used as a marker of inflammation in the last part of the small intestine, also called the terminal ileum, especially when there's been a resection right where the colon and small intestine meet. That doesn't replace colonoscopy because we need to see what's going on inside as well. But for small bowel disease, I talk with my hands a lot, so this is weird. For small bowel disease that's higher up that we couldn't reach with an endoscope, a CT enterography or a MR enterography are the appropriate tests to follow that up. And we would want to do that about 6 months or so after a resection or after making a major change in therapy to make sure that we're keeping things under control, treating any early recurrence of disease quickly and properly.
Thank you, Dr. Huff. The next one we will direct to Katie. What type of therapist would you look for in an area that doesn't have an IBD therapist?
That's a good question. Whoever's asking this and anybody, you're welcome to call me and I can help you with that. I actually field calls from all over the country because of my column. People want treatment that is going to really help them with chronic illness. You know, the people that I refer to are people that have experience working in chronic illness. I think that that's important. It's not always evident from a therapist's website, but generally if someone has an expertise and interest, it will be. So if you're looking for a therapist, look for that. Look for somebody that says that this is an interest and a specialty of theirs. There isn't a particular training program or like a certification that we have that says, oh, this person is trained in chronic illness. But so look for their own sort of statement that this is a population that they work with. I also want to say that therapy, because it is a very personal work, fit is super important. So when someone's looking for a therapist, I recommend that they grab some names, they look at the websites, they maybe get referrals from friends. As I said, you're welcome to call me, any of you who are looking for a therapist. Happy to help point you in the right direction. But again, interview therapists, give them a call, set up a Zoom call. You want to be sure that this is somebody that you feel comfortable talking with. Use your own instinct. Some people are more cognitively based, some people are somatically based. A therapist should be able to tell you how they work, how they treat chronic illness, and make sure that fits with you and what you're looking for. I also want to say that cost need not be an option. Again, there are therapists working at many cost tiers. I refer people for low-cost therapy at clinics that do very nice jobs all the time. So if it's something that you think you could benefit from, don't be deterred. Again, help is out there. I'm happy to help you access it.
I also wonder if after COVID, if location is really going to matter, just because I think many providers are seeing people via telehealth platforms or Zoom. So I wonder if going forward, if people in rural communities will have more access to different types of mental health providers.
I hope so. I mean, there's something about in-person therapy that is beneficial, But certainly from people that went screaming, I'd never do it. We're all doing it now. So we're finding ways of making it work for sure.
Dr. Huff, this one is for you. Which test is preferred? I think you did answer this in the chat box, MRE or CTE, and is the calprotectant not good for the upper small bowel?
Yeah, we talked a little bit about that, but yes. So calprotectin is not good for the upper small bowel, only colon and the last part of the small intestine, again, if you've had a surgery. As far as CTE and MRE, part of it depends on what your hospital that you are going to or getting your imaging does. If they have a specific test that they are more proficient at, that would be the one to use. I also typically like to use the same modality. So my go-to is typically an MR enterography. It is a little bit more labor intensive, and it is maybe a little bit more difficult for you, the patient, because you have to lay still for a longer period of time. But I feel like you can see the walls better, and it also, an MR does not give you a radiation risk or exposure, and especially in young women who may have to have repeat MREs over a long period of time, we try to minimize radiation exposure. So I typically, at Mercy, our radiologists are very good at reading MR enterographies. The technologists are very good at performing them. So that's typically my go-to. If I needed to get a CT enterography, I would be okay with that as well.
Just for those that don't know, could you tell us what MR and CT stand for?
MR is magnetic resonance. So that is this big tube that you get in, and it goes clunk, 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 and it's based on like magnet and frequencies. And then a CT, you know, I'm not sure I know what it stands for, but it is a radiation-based exam. Computed topography, I believe, but it does have radiation. It's a little bit quicker. The tunnel you just sort of like run through, and it's not as noisy. It can be a little claustrophobic, but both of the exams are a little bit longer than just a typical exam, because for the enterography part, which is what we typically order for inflammatory bowel disease, looking for small bowel inflammation, you have to drink this special contrast that actually makes your small intestine, instead of the normal size, it makes it expand a little bit so that we can see any inflammation or defects in the wall. So it is a process, because you have to drink the contrast, wait a period of time, and then go through the exam.
Thank you, Dr. Huff. And I think we've answered all the questions, and we've got 2 minutes left, so I think we'll let everyone go a minute or two early. I really want to thank Dr. Huff and Katie Willard-Virant for being on tonight and giving these presentations and answering the patients' questions. These types of events really wouldn't be possible without our volunteers. I did get another comment in the question and answer box from Barb Rosenbaum. Absolutely fantastic. She's so grateful that there are specialists out there to help IBD patients. So took the words right out of my mouth, and thank you all so much. And tomorrow I will send out an email with the recording and a brief survey for you all to take. And have a good evening, everybody.
Thank you.